Those of you in the audience who is wondering this long, confusing title, count me in, I'm with you, because it's difficult to understand even for me. But then finally, I found the light at the end of the title, age group, right? Now we know why I'm in this trouble, and this is because of the editorial that me with Professor Venkatram wrote this January in Journal of Hypertension, trying to correlate blood pressure and age, right? Blood pressure is a very important determinant in both diagnosis and management, and looking at several categories of blood pressure, right? For example, if we see a 20-year-old man, young man, who is scared of hospitals and needles, he has what? White coat hypertension. Okay, take the case of a 30-year-old pregnant lady. She has gestational hypertension. Take the 40-year-old computer geek. Okay, with all the metabolic abnormalities, with his stress, he works at night, he has isolated systolic hypertension of the young. And that you are looking at an 50-year-old hypertensive, no comorbidities. While this is a 60-year-old male with lot of comorbidities, previous MI, angina, AFib, LV dysfunction. And finally, you have that acute couple, isolated systolic hypertension of the elderly, stiff arteries, response to CCBs. And of course, finally, you have that frail 80-plus elderly, right? So you see, hypertension helps us in segmentizing or dividing people into groups of different categories, right? And that is why when we look at every hypertension algorithm, it starts with age less than 55 or age more than 55. Age less than 55, they respond better to RAS inhibitors, ACE or ARB, while older people have stiffer arteries and they tend to respond to calcium antagonists and diuretics, right? This is all known to us. So what we are trying to say is that if you take away the kids on one side, on the left, and the frail on the right, between them, the standard walk-in all-comer adult hypertensive, in this era of a long-acting combination therapy, what is the role of age as a hierarchy in the algorithm? In 2022, how do we consider age as an algorithm hierarchy? Let's look at the new data. This data, this is a large data, comes from London School of Hygiene and Health. This is a huge data looking at the first-line antihypertensive drug therapy and according to age, right? It's a huge data, look at that. It's about what? It's about roughly 1 million patient data, 1 million patient data, right? And here, if you look first-line hypertensive, comparison, let's say we'll look at the comparison between CCB-based therapy and ACE-ARB-based therapy. CCB versus ACE-ARB, right? Now, look at that y-axis, that is attained systolic blood pressure. Now look at the lower graph, right? That is those less than the age of 55 years. Now, if you note, there are two lines there, right? One is ACE-based therapy, one is CCB. They're overlapping, right? You can't make out two different lines. Now, look at the top line, that is age more than 55. Same, there are two lines, yellow and blue, but they overlap. What does it mean? Even more than age 55, whether you choose as a first-line ACE-based therapy or an CCB-based therapy, the response is same. So similar BP lowering efficacy of CCB or RAS inhibitor in all age groups, right? In all age groups. And if you actually look into the data of this publication, you see that 78% finally, over a period of 2007 to 2017, 10 years, 78% needed combination therapy, right? Now look at the number 2 data, even more interesting. This is, everyone would have seen that, age stratified, blood pressure stratified data that came from Oxford, 358,000 patient data. There's the BPL-TTC data, right? 51 randomized trials, 51 randomized trials. Now let's look at the data. Unreadable, unreadable. Let us zoom it up and see what we are interested in. Very, very interesting. Look at that. If you take out those who were treated with ACE inhibitors and ARB, RAS inhibitors together as a group, look at the data from those who came from 55 to 65 age group. So 55 to 65 age group treated with ACE or ARB. Add them up. They amount to 40%. 40%. Now, look at that last column. Age more than 85 years. Again, add them up. What? 40% received ACE plus ARB. So even very elderly did receive a combination of ACE and ARB rather than CCB or diuretic-based therapy. And now let us look into the age stratification, and that's what we are interested in, right? And here in the y-axis, you have what? Major cardiovascular events. The top line is those above the age of 85. The bottom, below 55. And put everything in between. Every category you see there's benefit, right? Every category you see there's benefit. So what are we trying to tell you? We are trying to tell you this, that all these years, age remained right on top of our head as a directive, as a hierarchy to decide what drug choice we are going to make in different categories. Suddenly, with introduction of newer therapy, long-acting combinations, it looks like everything has flipped, right? When we use a long-acting combination therapy, let's say a combination of CCB and a combination of ACE inhibitor, ARB, or a long-acting diuretic like a chlorthalidone, it looks like age as a hierarchy to decide subcategories have actually gone down and gone back. Lastly, let's look at the India ABPM data, which I am sure many of us, we did that with a lot of our colleagues and published them in 2019. There's an ambulatory BP data, 27,472 patients. This is the largest ABPM database from India that we collected, right? There were many surprising things, but this is the most surprising. 19.3% had masked hypertension. So 1 in 5 had masked hypertension, 20% had masked hypertension, which means daytime BP near normal, nighttime BP elevated. And they need a long-acting drug to control, obviously, because if you give a short-acting drug, what happens? Short-acting drug controls the daytime BP. For example, in India, we see that these prescriptions are very common, not from cardiologists, but from GPs, right? Enalapril, 2.5 milligrams once a day, minuscule dose. Losartan, 25 milligrams OD. Nifedipine, 10 milligrams OD. Hydrochlorothiazide, 12.5 milligrams OD. These tablets, given in the morning, control the daytime BP when the patient comes to the hospital, but not his night BP. He still has nocturnal masked hypertension. So the message should be, do not use them, right? Do not use them. If we look into the same data set, we again published it, depending on age, categorized on age, very interesting stuff come out. For example, here you see we are looking at masked hypertension, the same data set that we published, gray bar untreated, black bar treated. Significantly high number of people above the age of 70 has masked hypertension, right? So what are we talking about? We are talking about they are again candidates of long-acting RAS inhibitors and CCB. So yes, age is a very important determinant of subcategorizing several hypertension types, right? Not just hypertension. Look at Disney, right? If you want to get into a ride, there's an age limit, but suddenly it seems things have changed, right? And the kid seems to be enjoying that, so that you must be this tall to ride. But then what we are trying to say in conclusion is, ladies and gentlemen, most adult, non-frail, all-comer hypertensives benefit by long-acting combinations that all of us use today. CCBs, long-acting ACE, ARB, long-acting diuretics, right? And when we do that, it has basically altered the hierarchy of age-dependent guideline that is always on top of our head. Okay, of course there are exceptions, right? For example, if you have a young female contemplating pregnancy, you should not use a RAS inhibitor, obviously, right? If you are somebody who has a comorbidity, like an old MI or an angina or a AFib or an LV dysfunction, he needs beta blocker. We are not talking about that. But generally, age has gone back. We always say that in medicine, one size doesn't fit all, right? One size doesn't fit all in medicine, obviously. But then if you look at, this is Christmas, if you browse the internet, you see that particular socks is very famous now. That's a one-size-fits-all socks. A kid who is 5 years, 50 years, or 85-year-old gentleman, everybody can use that. Looks like combination hypertensive pills are following the same line. Thank you for your time and attention.